There's this misconception that women present differently than men. I would argue that actually women 99% of the time will present exactly like a man, but the way that they describe their chest pain is different. In the small proportion of people who say they did not have chest pain, it's more likely to be a woman that will not have chest pain. So while the vast majority of men and women present with pain, discomfort, weirdness in their chest, that small proportion that don't are more likely to be a woman.
It's no secret that women are incredibly adaptable, but in case you forgot, here's a reminder. During pregnancy, a woman's heart pumps 30 to 50% more blood than usual. That's not subtle. That's a full-body cardiovascular shift. From hormonal shifts to pregnancy to menopause, the female heart is incredibly dynamic, constantly evolving to meet your needs. So today we're giving the female cardiovascular system the attention it deserves. First up, Dr. Sahar Naderi, a cardiologist and researcher who specializes in heart conditions that disproportionately affect women and cardiovascular complications during pregnancy. Next, we have Dr. Marsha Stefanik. She's a professor at Stanford, a leader in sex and gender science, and an expert in chronic disease prevention. And finally, Dr. Neica Goldberg, a cardiologist, author, and founder of the NYU Women's Heart Program. Dr. Goldberg has spent decades pushing the field to take women's symptoms and risks seriously. Dr. Goldberg, Dr. Stefanik, Dr. Naderi, welcome to the show.
Thank you. Thanks for having us.
Dr. Goldberg, we'll start with you. You wrote a book in 2001 called Women Are Not Small Men: Life-Saving Strategies for Preventing and Healing Heart Disease in Women. What moment in your career did you first arrive at this insight?
Well, it happened actually in my very first job, which I started right after I finished my cardiology fellowship. And I was making rounds in the coronary care unit. And at that time, I was at the State University of New York Downstate Medical Center. And there was a person in the bed, and she actually was a hospital employee. She worked as an administrator in the pharmacology department. And I was surprised to see her because I went to medical school there. And I said, "What brings you in?" And she said, "Well, I went to 4 or 5 doctors, and with symptoms of throat tightness, shortness of breath, a little bit of chest tightness, and a couple of the doctors told her a range of things from you're stressed out, you need to take a vacation, and one actually gave her a prescription for Valium." And then she called one of my colleagues who said, "Come to the hospital." Luckily for her, she didn't have a heart attack, and they asked me to do a stress test on her. And she walked on the treadmill, and she was on the treadmill for barely a minute when she developed those symptoms, and her EKG became abnormal. Wow. So I stopped the stress test, had her sit down, and I called her doctor and to tell him the results. And mind you, he was my teacher a month earlier in my cardiology fellowship. And I said, "Oh, the patient likely has a clogged artery." And I said, "I think she needs an angiogram where we can do further testing to actually opacify the arteries and see where the block is." Anyway, he said to me, this really happened. He said, "Oh, she can't have heart disease. She's a woman." And I looked at him like he was from Mars. You know, she was overweight. She's a Black woman, single mother, high stress job, had high blood pressure. Yeah. She had all the risk factors, only that she had 2 X chromosomes. That was the difference than his, the image he had of someone having a heart attack. Wow. So eventually the nurse working with me said, "Can I speak to you?" Because she was a nurse, a cardiac nurse, for a lot longer than I was a cardiologist, only a month. And he came out of the room with her and said, "Okay, we're going to go forward." And then they did the coronary angiogram, and she had a 90% obstruction in the left anterior descending artery, which supplies the front of the heart muscle. So they opened that up. And then I said, "This can't only be happening to her." And then I got on a mission and I did a lot of work with the American Heart Association in New York and working with them. And then the national organization worked with them to launch the Go Red for Women campaign.
Well, it's so important that you took her seriously, that first patient seriously. Dr. Stefanik, your research focuses on chronic disease prevention. How has this space changed since you first got into it?
Well, I guess I'll start with my work with menopausal hormones and heart disease. So the PEPI study was the very first. It was called the Postmenopausal Estrogen Progestin Intervention Trial. It was launched in the mid-'80s. And we had to do recruitment saying, women, heart disease is an equal opportunity killer, because nobody believed that women got heart disease, just as Dr. Goldberg just said. And so I had been doing a lot of hormone research in rats and had come to the place where these hormones are really important potentially to prevent heart disease in women. That was the leading belief in the 80s. And so we did the PEPI study, we did a HER study, which was women with heart disease, and then we did the Women's Health Initiative, menopausal hormone study, all trying to find out, can we prevent heart disease in women? Because it was a leading cause of death in women. So to say it's not a woman's disease was crazy. And so that's really how I did it, because I was doing a lot of physical activity research. That's also what I do. And I actually wrote a grant trying to pit menopausal hormones against physical activity and saying, like, what's going to come out better in terms of, improving risk factors and preventing heart disease. So, and I'm still doing it. So these are both my research areas to this day.
Very cool. Dr. Naderi, who is here with me, you specialize in cardiac conditions that disproportionately affect women. What made you so interested in this in the first place?
Oh gosh, that's such a long story, but I initially came into medicine because I was very much interested in marginalized communities and disparities in health. And I thought I was going to do adolescent medicine in the inner city. And then when I started internal medicine residency, there was something about cardiology that really drew me. It felt a little bit more kind of concrete and tangible than some of the other specialties that I had experienced. And adolescent medicine is just it's a very emotional time, and I wanted something more concrete. So over time in residency and fellowship, I thought, well, how can I bring those two together? And you realize as a female cardiologist in a male-dominated field that doesn't focus on women so much, and still didn't focus on women 10, 15 years ago when I was in training, that actually married those two interests so beautifully for me. So I ended up actually being the first women's heart health fellow after cardiology fellowship, I think, in the country, because there was a generous donor at Mass General who wanted to build out this career for fellows that were interested. And so I think the stars just aligned, and here I am.
Very cool. Well, we should stay on you then to talk through the basics and just set a baseline. What does the cardiovascular system include?
That's also a loaded question, but if we simplify it, it includes the heart muscle, the electrical system of the heart, the plumbing, as I like to call it, so your coronaries, but it also includes the brain vessels and the vessels in your legs into your vital organs. And that's really the focus of cardiovascular disease. So it's a big umbrella of a lot of different conditions.
Okay. Dr. Goldberg, what are the characteristics of a healthy heart? So if we're looking for just, healthy, optimally running heart, what does that look like?
Well, a healthy cardiovascular state is a heart that has never been affected by a heart attack, and coronary arteries that don't have any plaque buildup or cholesterol buildup in the walls of the arteries, and that you have a normal blood pressure, which optimal blood pressure is 120/70 for anyone of any age. And you have normal blood sugar and a cholesterol that's in normal range, and that you're leading a healthy life. You don't smoke and you exercise, and no one's perfect is what we all know. People don't always eat a healthy diet, have trouble quitting smoking, and don't find the time to exercise because they're working all day. So we have ways to check the heart to see if you have cholesterol buildup, or you can get a simple visit with the doctor to get your blood pressure checked and get your cholesterol and glucose checked to make sure that you have those in the normal range. And if not, they're acted upon.
Yeah, yeah. Dr. Stefanik, what does having a healthy heart feel like in just day-to-day life?
Oh, feel like, well, that has to be a personal experience. I can't be speaking for everybody. I am a exerciser. I used to be a marathoner. So for me, a healthy heart means that I can do all of this endurance activity, but that's not true for everybody. So, I don't know. I think everybody has to answer for themselves whether they feel that their heart is healthy. Right now, coronary artery calcification is a big thing that people are talking a lot about. And so I feel like I don't know what my coronary artery calcification looks like. So I don't know if I actually have a healthy heart. I can only say that it feels like it's healthy.
Okay. Dr. Goldberg, how does the female heart differ from the male heart structurally, functionally, physiologically?
Well, structurally, both men and women have a heart that has 4 chambers, 2 on the top, a right and left, and 2 on the bottom. And our aorta comes out of the heart to deliver the blood flow to the rest of the arteries in the body. Proportionally, women's hearts are smaller than men's hearts. It's interesting, women have a higher heart rate than men.
Based on these differences in a male heart and a female heart, Dr. Naderi, does that mean our healthy ranges for blood pressure and cholesterol might be different as well?
Generally speaking, no. I think the main difference, in my view, of men and women is the greater focus in our reproductive lifespan for women. So for women, for instance, if you have a hypertensive disorder of pregnancy, preeclampsia, hypertension during pregnancy, autoimmune conditions disproportionately impact women. So like lupus or rheumatoid arthritis. Right. If you go through early menopause under the age of 40, polycystic ovary syndrome, there are conditions that might make one want to be more aggressive with a woman than a man, given those circumstances.
But in general, the ranges that you're looking for normal
are generally the same.
Okay. Dr. Goldberg, let's go back to your initial time as a cardiologist, that first month you were a cardiologist. Historically, heart disease was thought of as a male disease, as you found in your lived experience. Where do we now know that misconception came from?
Well, it started a long time before I started my cardiology fellowship. There's a long-standing body of research called the Framingham Heart Study, where they study the population of Framingham, Massachusetts. And the research project started in 1948. And there are a series, and they look at the research data in different time frames. Maybe it was every 10, 15, 20 years down the line. And there was a publication from the Framingham Heart Study where they looked at women coming into the medical offices with chest pain and men coming in with the symptom of chest discomfort. And they found that more men were likely to go on to having a heart attack or needed intervention for their arteries, and the women did not. So the conclusion from that was that chest discomfort was a benign condition in women. But there were some problems with that because they assumed that men and women of the same age were going to have heart attacks at the same time. And what we know now is when they went further out and the women got older and went through menopause, many more of those women were having heart attacks. And somehow that didn't infiltrate medical practice the way the initial look at did. And so now, as cardiologists and researchers, we're playing catch up to looking at how we can better diagnose heart disease in women, how we can better encourage women and their other healthcare providers other than cardiologists, screen them for heart disease risk factors.
So there has been an evolution. Dr. Naderi, when we think about heart disease, we often think about and talk about heart attacks, but what are some other forms of heart disease, specifically conditions that are more likely to have an impact on women?
Yeah, so there's recent research that actually shows that in the United States, we're not dying of heart attacks anymore, but we're seeing increased mortality and increased incidence of heart failure and arrhythmias and other parts of cardiovascular disease. So I would say, beyond just a heart attack, heart failure, arrhythmias are two really important ones. Beyond that, we know that there are conditions that disproportionately impact women, particularly around menopause, such as broken heart syndrome or stress cardiomyopathy. The area that I have particular research interest in, spontaneous coronary artery dissection or SCAD, and also this entity of MINOCA, which is myocardial infarction with normal coronary arteries. So these are a lot of just kind of fancy terms to say there are conditions that seem to disproportionately impact women that we also have to recognize as we think beyond just heart attack and coronary artery disease.
And how might symptoms of any of these cardiovascular diseases, this buffet of cardiovascular diseases that you just presented to us, how might they present differently in women versus men?
So this tends to be one of my pet peeve questions, not because you asked it, but because there's this misconception that women present differently than men. I would argue that actually women 99% of the time will present exactly like a man, but the way that they describe their chest pain is different. So women will say, I just felt some heartburn, or it just felt uncomfortable in my chest.
Because socialized, we play down our discomfort.
Exactly. So it's still pain.
Right.
Per se.
We're just not
just describing
as upset about it. Okay.
Right. And then in the small proportion of people who say they did not have chest pain, it's more likely to be a woman that will not have chest pain. So while the vast majority of men and women present with pain, discomfort, weirdness in their chest, that small proportion that don't are more likely to be a woman.
Okay. Dr. Goldberg, did you want to add something?
I wanted to add that I think the point you make is excellent. Men and women communicate differently, and that has to be appreciated. And oftentimes women will say they have a tiredness in the chest. And it's really important to ask a patient open-ended questions. Instead of saying chest pain, you would say, have you had any discomfort in your chest? What does it feel like to you?
Okay, open-ended questions. Dr. Goldberg, let's stay on you. Why is something called the high sensitivity C-reactive protein known as a silent alarm bell for women?
The high sensitivity C-reactive protein is a simple blood test. You go to the lab, you get a blood draw, and the C-reactive protein measures inflammation. And everybody knows the basket of risk factors: high blood pressure, cigarette smoking, high cholesterol, diabetes. But inflammation is a stimulus for the deposition of plaque or cholesterol in the coronary arteries. And this is one way that we can measure in an office-based procedure your cardiovascular risk. Where is it best used? Well, the original study that looked at C-reactive protein used it in men 50 and over and women 60 and over. But it's really, really very important to know that we have other tools. Another blood test that we can draw that is a hereditary factor that is especially important to use in people who have a long lineage of heart disease in their families, or someone who comes in and has a heart attack and has no obvious risk factors. And that's something called the lipoprotein A, which is a cholesterol protein that carries bad cholesterol. And some studies also point to the fact that it may increase blood clotting.
Okay.
And it's an active area of research now for drugs that lower the lipoprotein A. But if someone should have that risk marker, it increases risk for heart attack and stroke, and we lower their cholesterol to their bad cholesterol to less than 70 or 50 to 55.
Dr. Stefanik, what role does estrogen play in our cardiovascular health?
Well, this is a very big debate and it's still going on. So I will say that when we first started this prevention work, it was very much believed that estrogen would prevent heart disease. And as we were talking about earlier in the studio, they did a big study called the Coronary Drug Project that only had men, and they gave men very high doses of estrogen, and they had strokes and heart attacks, and they had to stop that trial. They then proceeded and they did the PEPI study where we looked at different estrogen and progestin combinations, and you can't just study estrogen. Now, the problem is that we only study conjugated equine estrogen, so it's one type of estrogen. But the data that they were bringing forward was from the Nurses' Health Study, from Framingham, from the LRC Lipid Research Clinic. And basically, we've learned that there was a lot of biases on who was taking menopausal hormones. So they were a healthier group of women. They went to their doctors. You had to get a prescription. They had the blood test. They got their cholesterol checked. So I was a lipidologist at one point, and we had this belief that HDL cholesterol was the most important thing in women, and that's also been all debated. So, science is a process. And we just keep learning new things and interpreting things and then reinterpreting things. So with estrogen, I will say that the Women's Health Initiative was the primary prevention trial to see, could we prevent heart disease with this conjugated equine estrogen in older women? So it had nothing to do with menopause, which is part of the new problem because managing menopause also needs to be researched. Like that is like a serious thing that women experience. But we were not studying that in the Women's Health Initiative. We were studying prevention. And we had done the HER study, which is a study of women with heart disease. I will tell you that in 1997, the American College of Cardiologists put in their guidelines that if you have a woman with heart disease, you should consider putting her on menopausal hormones without clinical trial data. We were already doing the HER study. And in 1998, we published that it did not prevent heart disease. And in fact, it increased your risk of having a heart attack by 50% in the first 6 months because of blood clotting. So to the other points that have come up, estrogen affects blood clotting. Estrogen affects cholesterol. Estrogen affects a lot of other things, vasodilation. So it's a very complex story. It's not a simple story. And when we talk about that, adding progestin in the Women's Health Initiative, the combination of estrogen and progestin caused a whole bunch of risk factors that we didn't see in just the estrogen-only group, but the women were actually different. So it's very complicated, and it isn't something that you can just come up with a soundbite, like what is the answer to estrogen? Right. It's a complicated answer. And I will tell you that it's not just hormones. We talked about the XX. It's like we have so much information now about how important it is to have two X's and no Y in terms of how your heart is built. So we actually get different kinds of heart failure. We now know that, women are more likely to get heart failure with preserved ejection fraction, which just basically means the wall of the left ventricle, which is one of those lower chambers, gets very thick. Whereas for men, it gets very thin. They have a different kind of heart failure on average. So when we say that, women and men get all the same things, but they're slightly skewed this way and that. So I think we need to go way beyond hormones, and we need to look at the hormone interaction with the basic biology of having XX in every cell of your body. So every cell of your body has sex.
Right.
And we need to be thinking through that in a much more complex way. And we're on our way. But unfortunately, people want sound bites. They want to make it simple. And this is just not simple stuff.
And we have been talking about estrogen, but not progesterone. It's often framed as estrogen's sidekick. Does it independently affect blood pressure and stress response?
So estrogen and progesterone and how they impact the cardiovascular system, as Dr. Stefanik said is a very loaded question. I think at the end of the day, the way that I approach these questions is to think about building a care team around the woman with a cardiologist and a menopause specialist to talk through the pros and cons of quality of life, quantity of life, cardiovascular risk, to determine what is appropriate and of appropriate risk for the individual patient. I get very reluctant to kind of talk through, how these different hormonal players impact cardiovascular risk, because a lot of it we still don't know.
Right. And just to be clear, you're saying that essentially our systems are so complex that it's not just the amount of a hormone, one hormone or the other, but also the fact that there's XX in our cells and that there's fluctuations in these hormones, and how they fluctuate makes a difference too.
Right.
Okay.
They're interdependent. Everything's kind of related to each other. They're little pieces of a jigsaw puzzle, right? And so, for instance, women around menopause, when you check their hormone levels, they can still be normal, but that doesn't mean they're not going through menopausal change. So there's a lot we don't know about hormones and how they interact, and there's not a silver bullet to figure it all out, if that makes sense.
Right. Dr. Goldberg, what about for premenopausal women? Does a healthy menstrual cycle temporarily change any of our cardiovascular markers?
Well, in terms of women around perimenopause, your cholesterol profile can change, where there can be an increase in LDL cholesterol and triglycerides, and the HDL cholesterol either remains the same or can decrease a bit. In terms of going through perimenopause and menopause, we start to pick up increases in blood pressure, because as estrogen levels decrease, the blood vessels lose their flexibility so that they become a little stiffer. And so that leads to high blood pressure. Most people don't realize that the blood pressure we measure in someone's arm is really the force that the heart is pushing the blood against when it goes out the aorta to the other blood vessels. And so if that's tighter, you're going to have high blood pressure. I will also add, since Dr. Stefanik brought up that she's a marathoner, there are some really good exercise studies that show regular aerobic exercise can actually improve our arterial flexibility. So that's one of the things. In terms of around perimenopause and menopause, we also see a rise in some mental health issues in women, like depression. And although there's not a direct correlation between depression and heart disease risk, we also know from studying women with depression, because they're depressed, they're not able to do the healthy things they can do for their lifestyle.
Let's jump to polycystic ovary syndrome, or PCOS. It affects 1 in 10 women. How does this condition have an impact on heart health, Dr. Stefanik?
Well, it's very similar in terms of increases your risk for premature heart disease by almost twofold. So it's definitely an important issue. It relates something to insulin resistance, but it's also very similar to having gestational diabetes in terms of its increased risk for premature heart disease when you're pregnant. So we do worry about that history of PCOS.
Yeah, and because it is somehow related to insulin resistance or is similar to diabetes, I'm curious where y'all come down on whether an effective intervention would be something like a GLP-1 or a metformin, which is used to treat diabetes. I know that that's kind of a debate these days.
Yeah, I think, that we're early in the stages of that research, and having been in research for so long, I feel like I don't want to say anything really definitive at this point, but it definitely does reduce body weight. Our key is always going to be, is it visceral adiposity? So that's the fat that's in your abdominal area as opposed to subcutaneous fat. So a really important thing in the whole obesity work, which I did a lot of research on obesity, is that it isn't your body mass index or your total body weight. It's where that fat is stored that's the key to both insulin resistance, diabetes, not just both, but diabetes, heart disease, everything. We're very clear that having this particular kind of obesity is really important. And some race and ethnic groups have more of the visceral adiposity than others. So, just having extra fat is not bad if it's in the subcutaneous space, which is true of premenopausal women. But one of the things that happens with a menopausal transition is you slowly redistribute your fat from the subcutaneous, which is why we start to get really thin skin, to the intra-abdominal area, which is all around your organs.
I keep saying this, so much to look forward to. Every time we talk about menopause, I'm like, yay, redistribution of fat to an unhealthy place. Dr. Naderi, let's jump to SCAD, since you do specialize in treating women with spontaneous coronary artery dissection, or SCAD. Could you tell us what SCAD is again?
SCAD is a condition that ultimately results in a heart attack similar to plaque-related heart attack, but it's what we think a rare condition, but probably the more likely cause of heart attack in women under the age of 55. This is a very active area of research that we don't quite know the answer to. It seems to disproportionately impact women around menopause, but was originally actually described in pregnancy. So we know it's also a cause of heart attack around pregnancy, particularly after delivery. 99% of SCAD patients are women. Yeah. So we know there's some hormonal driver to the condition, but a lot of the questions that folks have around what causes SCAD and what are the triggers of SCAD are areas we're still actively researching.
Okay. Dr. Stefanik, what is the relationship between adverse pregnancy outcomes and cardiovascular risk? This is something you have studied.
Yes. So we just finished a big study of women who were pregnant and then either got hypertension during pregnancy or didn't. And we also studied women who had that history. And we see a lot of things that change in the blood because of preeclampsia, this hypertension. It's actually from the placenta. So the solution to that is that you do a cesarean delivery and you get the placenta out of the picture. So the placenta is another huge contributor to what's going on with adverse pregnancies that we're just starting to understand. But I also would like to say something about the hormones that you just mentioned. It isn't just the type of hormone. So we can talk, I mentioned before conjugated equine estrogen, which was the predominant menopausal hormone of the past. Now we're using different estrogens, but it's also how you take that. Like if you take it through a pill, it goes through your liver, and that will basically stimulate a lot of biochemical things that will cause the blood clotting and will cause different factors to happen. But if you take a patch, which I think somebody referred to before, that's called transdermal estrogen, a very small percent will go through the liver, but most of it will go into the systemic system. So you get very different physiological responses depending on the route of administration. So a pill versus a patch, and I think currently menopausal specialists are preferring patches over pills. Problem with the patches is they often get allergies to the patch because women have sensitive skin. And also when you talked about progesterone, I will say that progesterone affects the gynecological systems a lot more than the cardiology system. So it really plays a different role on the uterus. And the reason you would take a progestin with an estrogen with menopause is to prevent cancer of the uterus. But it also has an interactive effect with estrogen in the breast that increases your risk of breast cancer. So it's kind of like you're protecting yourself from one cancer and increasing your risk of another cancer. I don't think the data on progestin's effect on the cardiovascular system are really well studied at all. We did study that in the PEPI study. We had 3 different progestins. So we studied micronized progesterone, patch progesterone, a daily progesterone and a cyclic. So whether you get it cyclic, whether you get it daily, there's a lot of pieces, and we are getting there. So the good news for the women going through menopause now is that we finally are paying attention to menopause. I can tell you in my era, we pretty much talked about premenopausal women and postmenopausal women, as if there never was a transition to get there. You just were there overnight. So we're in a whole new world now where we realize quality of life is in fact important also for cardiovascular risk.
Let's stay on pregnancy just for one more question, Dr. Naderi. How might pregnancy rewire a woman's cardiovascular system?
So pregnancy is an interesting time because sometimes we say it's a bit of a stress test for the heart. And so it will bring out sometimes a lot of things that were silent or were not in existence prior to pregnancy. So it's a time where women can develop high blood pressure and preeclampsia, which is a condition where the blood pressure goes up. And in most cases, there's protein that spills into the urine. And so those are indicators of perhaps the heart's not feeling so happy with everything that's happening with baby and the placenta, as Dr. Stefanik said. So I think those are things that can come to fruition during pregnancy, other things like gestational diabetes and whatnot. So I think the important thing is when those things develop is to make sure you have a care team around you who's following you closely, and also have the recognition that unfortunately, once baby comes out, that doesn't mean that was a thing of the past, but that it does increase your lifelong cardiovascular risk. So you need to be more vigilant about your cardiovascular health than perhaps your counterpart who did not experience those issues in pregnancy.
Okay. Dr. Goldberg, what happens to our heart health after menopause when estrogen levels fall?
When estrogen levels fall after menopause, we start to see a jump in high blood pressure, and the cholesterol starts to rise. So we see increases in the LDL, which is the bad cholesterol, and the triglycerides. And then we also see an increase in belly fat. And actually, that's one thing that patients comment upon very often. It's like, how do I get rid of this stuff around my belly? And and that's a common thing that comes into the office. And and then we start to see a rise in heart symptoms and potentially for women who weren't screened early enough, or there was an intervention in their risk factors, they can have chest discomfort or angina and end up having abnormal stress tests, and they have coronary artery disease, and others who have heart attacks.
I'd love to shift the conversation to stress and chronic stress. Why don't we start with you, Dr. Naderi? How does prolonged stress affect heart health?
So there's always these interesting graphs looking at cortisol release, right? Because back in the day, right, we were escaping bears and predators, and we needed that cortisol release and that fight or flight. And now in the modern era, we're seeing that kind of cortisol release, fight or flight, there seems to be a low trickle of that all the time. Like we're all a little bit stressed, we're all a little bit more wired. And there's increasing evidence that shows that kind of chronic low-level stress, that chronic maladaptive, as we like to say, cortisol level is causing increasing effects on our cardiovascular system.
What is happening biologically, Dr. Goldberg, when cortisol floods our system or even kind of just drips into it chronically?
Like other hormones we've been discussing, it is a bit complicated. But what we should say is when cortisol is secreted and there's increased secretion with chronic stress, it can raise your blood sugar and also blood pressure.
Okay.
And in fact, in one group of people that we see increased cortisol levels are those people who have sleep apnea or interrupted sleep. And they're actually prone to cardiovascular disease and heart arrhythmias.
Dr. Stefanik, is stress more of a risk factor for women than men?
Oh, interesting question. I don't know the answer, and I know a lot about sex differences. I think that we really haven't been able to define stress in a way where it's easy to measure what you mean. But I think that we do know that women are more likely to be depressed, have anxiety disorders. So there's a number of things that are related to stress that are higher in women. And we do know, as we've been talking about, that there's a relationship to that, to heart disease. Women actually experience pain at higher rates than men do. It's not true that women have lower pain thresholds. They have higher pain thresholds. They feel pain more readily. But whether that's related to stress is a different issue altogether.
Okay. Dr. Naderi, while we're on the topic of stress, do you want to talk a little bit about stress cardiomyopathy?
Sure. I want to make a point that for the audience, that we don't want to get stressed about being stressed. So I see that commonly. We talk about how important stress is for the cardiovascular system. And then I find sometimes my patients just get anxious about, like, oh gosh, I'm stressed. So, what's going to happen? So I think the most important thing to get out of the discussion of stress is, are you able to sit with your stress in an adaptive way, in a healthy way? So you don't push it away. You sit with it for a bit and say, I'm feeling pretty stressed. But then you don't let it carry on through the rest of your day. So I think that's a really important point, is that we're all going to be stressed. We all have tragedies in our lives. We all have really difficult things that happen in our lives. And you're not meant to push those away. They're part of being a human being. But there are ways to make sure that it's not bleeding into every part of your day constantly. So I think that's the important part of thinking about stress. Now, to your question, there is an entity called stress cardiomyopathy that seems to disproportionately impact postmenopausal women. And the classic description is a woman has a tragedy in her family, or the loss of a pet, or something along those lines, like a sudden, very stressful cortisol release that leads to oftentimes shortness of breath, chest pain. And when the woman gets taken to the cath lab to look at the coronary arteries, because by all intents and purposes, it looks like a heart attack, the coronary arteries are normal. But the heart has this takotsubo, which is Japanese for octopus trap type of characteristics, where the bottom of the heart's pumping okay and the tip of the heart's ballooned out.
Whoa.
And that entity resolves itself largely for reasons we don't fully understand within 4 to 6 weeks.
Whoa.
But it's mainly thought to be a stress-triggered entity. There's a lot more research around it related to perhaps the small microvasculature of the heart is not normal, and a lot of different areas of research that are fascinating to a cardiologist. But that is one entity that we know disproportionately impacts women and oftentimes has a clear stress trigger. Not always, but oftentimes.
Dr. Goldberg, how does poor heart health accelerate brain aging in women? What do we know about this?
As Dr. Naderi started off our conversation together, we learned that the blood vessels are all connected like branches in a tree. And the tree trunk is the aorta, and there are all these branches. And a lot of these blood vessels go to the brain. And what we see is the connection between, let's say, heart disease and cerebral vascular disease or brain disease, is that the blood vessels in the brain also have the buildup of plaque, and that can increase risk for stroke. And that we know that people who have chronic heart disease may have blood vessel disease in the brain, and they might have a series of small strokes leading to vascular dementia. So this is important to take care of the heart and the brain. And I also want to point out that untreated hypertension is one of the leading causes of strokes, risk factors for heart failure, heart attack, and stroke.
Dr. Naderi, mental health has an impact on heart health, but the reverse could also be true. What connection have you found between PTSD and SCAD, your area of specialty?
Yeah, so last year with Dr. Sumner, one of the cardiac specific psychologists at UCLA, we looked at the rates of PTSD in our SCAD cohort, which is our international cohort of SCAD patients. And we found that the lifetime incidence of post-traumatic stress disorder was about 30% in our cohort, which is substantially higher than the average population. You could argue higher than those who've been in combat, so really high rates. And the other part of the research was that we found that about 50% of those who reported PTSD did not seek or did not get care. So I think one of the main things that we're all struggling with is just the mental health crisis in this country and the lack of support, particularly after COVID, to support all of these women who really need intensive therapy and need more support in this space. So we're raising the issue as important. How we're going to solve the problem, I think, is the next step in the bigger question.
For women out there who are concerned about their heart health, what tests should we be getting beyond the standard cholesterol panels? Dr. Naderi, you want to kick us off?
I get this question often. One thing I will say, going back to what is the definition of high blood pressure. So probably until about 5-10 years ago, we'd say anything less than 140/90 and you're cool. That has really largely changed. But perhaps the community catch up to that change has not seen itself fully. And so a lot of women are going to their practitioners and being told, you're close enough, you're good. But actually, we really, if you want to be a purist, yes, closest to 120/70. And if you want to kind of look at the community as a whole, we would say 130/80 at least and lower. If you have cardiovascular conditions, we might want to even be more aggressive. So I think the first thing beyond labs is just what is normal blood pressure, and just make sure that your care providers are actually using the thresholds that we use in the modern day.
Okay.
In terms of labs, I try to get very individualized on this because I'll find that a lot of times women will come to me asking for a test that may not be appropriate for them. So I like to look at patients as those that we're looking at from a primary prevention standpoint, meaning you have no cardiovascular disease. So that's one bucket of patients. And the other is for secondary prevention. So those who've already had a heart attack or have cardiovascular disease, the testing and recommendations may be different. So I think you have to kind of think about this as which bucket do you fall into. So we're going to just talk purely about the primary prevention folks, the ones who don't have cardiovascular disease. And for those, I think, a lipid panel, obviously, which you mentioned is standard. I'm a big fan also, like Dr. Goldberg, of the lipoprotein (a). As she mentioned, and this might be a misconception in the community, that there is a treatment for lipoprotein (a). There is not currently. There are FDA-studied drugs that will probably be coming out in the next 2 to 3 years. But the nice part of having that test and knowing if yours is abnormal is it gives you another piece of the puzzle if you have a family history and whatnot. So I really like the lipoprotein (a). I'm not as much of a high sensitivity CRP fan. I'm not really sure if that really changes how I look at folks, but I do really like the calcium score. So I usually will do a lipid panel, a lipoprotein (a), and a calcium score in folks that are over the age of 45, because that's where the evidence is, to kind of round out their risk, particularly if they have a strong family history.
Let's just back up really quick. What is a calcium scan and what does it measure?
Basically measures the amount of calcium in the coronary arteries and takes that number and turns it into a percentage risk based on your age and sex, I should say. And then it's used as a piece of the puzzle in a lot of the calculations we use to look at cardiovascular risk and whether there's an indication for more robust cardiovascular therapies, like with a baby aspirin or with a statin. It does not tell you if you have atherosclerosis per se in your coronaries. Calcium is a component of plaque. And if you have a high calcium score based on your age, and sex. It may indicate that there might be more atherosclerosis in your coronary arteries. And it's another piece of the puzzle we use to determine whether you should be on therapy to lower your cholesterol.
Real quick, since we didn't define it, what is atherosclerosis?
It's basically the complex composition of plaque in the arteries.
Okay.
One thing that's important is there's certain ethnic groups, particularly like South Asians, where they may not have as high of a calcium score and they have more soft plaque. And so calcium scores may not be as helpful. Those patients, Pacific Islanders, tend to have early coronary disease, but the markers for heart disease don't necessarily apply to them as strongly. So that's why I say you have to kind of individualize care, because there's a lot of nuance and there's not like go to your doctor and have them order this panel, because it can vary from person to person.
Yeah. Dr. Goldberg, while these calcium scans aren't routine tests, mammograms certainly are for women above the age of 40. A recent study found that not only do mammograms screen for breast cancer, but they can also spot heart health risk. Could you tell us about this finding?
Well, on mammograms, there are two types of calcium. One that's in the tissue of the breast, and the other is the calcium buildup in the arteries to the breast. And the breast arterial calcifications are also a marker of cardiovascular risk. And so I actually have had patients referred to me because they've had breast artery calcification. And it's great that they get to come in and get screened. And that's being picked up by the medical community.
And then any of you doctors can jump in on this question. Are there particular genetic markers that women should be paying attention to with respect to heart disease?
So I can jump in. There's a entity called familial hyperlipidemia, largely in folks with an LDL, or bad cholesterol as we would call it, above 190. In that subset of patients, family history of early heart disease, LDL over 190, there can be consideration for genetic testing. Okay. And that informs how aggressive we are in lowering their LDL, but also informs testing of children and first degree relatives. So that's the main one that comes to mind. Certainly lipoprotein A has a genetic component as well, and kind of falls into a different bucket, but those are kind of the main areas of genetics I see for heart disease.
We use genetic testing for other cardiovascular conditions, such as a condition known as hypertrophic cardiomyopathy, which is an inherited thickening of the heart muscle, as well as certain types of arrhythmias. Okay. When we learn that arrhythmias occur in the family, or there's been sudden death due to an arrhythmia, we can do genetic testing for that.
Dr. Stefanik, you have studied so much exercise. What do you think about Fitbits and Oura Rings and other fitness trackers as a way to gauge our heart health?
Well, I think mostly it's a way to motivate people to exercise. So I think the data on that is that some people really like tracking their physical activity, and it motivates them to do more. So I would say anything that motivates you to do more, or at least to keep up the level you're doing, is fantastic. I don't know that the Fitbit per se does much for your heart health, but the Apple Watch, there are mechanisms now where you can see, am I getting AFib, atrial fibrillation, which is an electrical condition. So we have people who have studied that at Stanford, and these are great ways for you to monitor what's going on with your cardiovascular system. But you might actually want to ask the cardiologist about that. I mostly love it for getting people to exercise more.
Yeah, because there have been these headlines in the news that somebody's exercise tracker has been able to detect some sort of, abnormal heart condition, right?
Yeah, it's a little bit of a catch-22, because for every time that it detects atrial fibrillation, there's probably 10 patients who tell me, my heart rate dropped to 30 while I was sleeping, which can be a normal physiologic response, or, they were in a scary movie and their watch went off and said something was happening. I actually had a patient recently who came in that the watch went off, and it had tracked that she was she was not balanced, like she was a fall risk, because she was just making a lot of motions with her hands while she was talking to her friend. So, and it's not to at all poo-poo like these technologies, but it's just to kind of know that they're fallible and they're not perfect, and that you have to use them in a way that's like, they're not the end all be all. If they detect something, you can reach out to your physicians to make sure that it's actually something. But we get quite a few emergency room patients that come in because their watch went off. So I think it's a little bit tricky. The technology is not perfect yet. There's certainly stories of these amazing, miraculous, life-saving things it's picked up, but you just kind of have to use them with caution. And I will say, as someone who lives in the Bay Area and sees a lot of folks in tech, sometimes more data is not more better, if you will. Sometimes more data makes people more anxious. Yeah. So you have to kind of know who you are and make sure that you educate yourself on the capabilities of what you're using and, kind of their boundaries.
That makes sense. All right, let's jump into audience questions. First question, and raise your hand if you want to take it. When someone tests positive for high cholesterol, why might the standard advice of diet and exercise not always be the right solution? All right, Dr. Stefanik.
Having studied diet and exercise for many, many years, it doesn't work for everybody. And the biggest problem is you can't get people to do it. So if you can get people to successfully change their diet and exercise, it works a lot better than if they don't do it.
Okay. What are some other solutions that can help, promote heart health that are outside the standard diet and exercise recommendations?
Well, I'll just quickly say that, it used to be that they recommended that you started with diet and exercise, and you did that for 6 months. And if it didn't work, then you would move on to statins or other treatments that they're using now. But I think they just gave up on believing that people could do it. And so they just pretty much go right to the statins. And the cardiologist should confirm that that's true.
Well, one of the things is, Dr. Stefanik, is that we don't let people wait as long as 6 months. We give them 3 months of a diet and exercise program, because I think it's important to reconnect with the patient to see if they're following the diet and exercise program and what the impediments are. In terms of how we lower cholesterol when diet and exercise are not enough, is we have cholesterol lowering medications. The most commonly used one are the statins. We also have non-statin drugs. 2 of them are ezetimibe and bempedoic acid. Actually, I should say 3. There's another injectable medicine called a PCSK9 inhibitor. But generally, the first line of cholesterol medication is statin medication. The way I explain it to my patients is, even though you're going on medicine, it's important to follow a Mediterranean style diet and to exercise. And I also tell them that might help us staying on a lower dose of medicine. There are other supplements that are touted to lower cholesterol. So first of all, omega-3 fats. A lot of patients ask when they're diagnosed with high cholesterol, can I just take over-the-counter fish oil? So omega-3 fish oil actually lowers triglycerides. It doesn't lower LDL cholesterol. So if you have a problem with the LDL cholesterol, the omega-3s aren't going to work. Another commonly used supplement is red rice yeast, and red rice yeast has a similar composition to 2 of our earlier statins, simvastatin and torvastatin. So in fact, people who are taking those medications can actually get similar side effects. And they should share that information with their doctors, because it would not be good to be on the supplement red rice yeast and also take a statin, because then you have increased risk for side effects.
So you've talked about different statins, or we've just talked about statins as a way to lower cholesterol. What is statin medication? How does it work? What are some examples?
Statin medication is an oral cholesterol medication that works by inhibiting an enzyme in the liver called HMO-CoA reductase. Big name. And it inhibits it so they you decrease production of cholesterol. And that's the mechanism by which the statins lower cholesterol. There are several statins available for prescription. They've been around a long time. And we generally, when a patient comes in and says, which one should I start, doc? It always depends upon what their cholesterol level is and what their insurance plan pays for.
Okay.
So that's how we choose the statin.
Okay.
Hey, can you ask her something about the symptoms of statins? Because this is something where people talk about this muscle pain, and I'm really curious myself because...
Oh yeah, are there side effects? Are there certain known side effects of taking statins?
Well, there are side effects to all medications, including statins. Some of the common side effects are muscle aches. There can be GI upset and liver function test abnormalities. Now, the muscle aches are very nonspecific, so it's really important to make sure there's not something else going on. It's like you started an exercise program and you pulled out your muscle the same day you started the statin. It's probably from pulling your muscle. Vitamin D deficiency can also predispose you to muscle aches, so it's really important to get a vitamin D level on someone when you're considering statins to make sure the vitamin D level is normal, or give vitamin D supplementation. We can do a blood test called a CPK test to see if there's been muscle damage or inflammation. And if it's very high, then we stop the medication or lower the dose or try a different class of medication for that patient to lower their cholesterol.
Dr. Goldberg, while we are on the topic of various medications, mental health meds like SSRIs can affect heart rhythm from what we understand. What should women monitor if they're on these medications?
SSRIs can actually raise blood pressure. So it would be very important if they're on blood pressure medications to consider taking home blood pressure measurements while they're on the medication. And if their blood pressure should become elevated on the medication, and the SSRIs are very good in treating depression, so that person would be given a clinical plan to treat their blood pressure. In terms of arrhythmias, sometimes there could be changes in the electrocardiogram with what we call the waves of the electrocardiogram. If you've ever seen an electrocardiogram, there's a series of waves.
Right.
Well, there's something called the QT interval, and sometimes that can increase the QT interval, which may predispose you to some arrhythmias. But it's likely that when you go on the medication, the person who's prescribing it will recommend an electrocardiogram, and you will probably follow up with that doctor at various times. I will point out there have been studies that the SSRIs are perfectly safe to use in people with heart disease. Mm-hmm. And although they treat depression, they don't lower the risk for heart events in people with existing heart disease or at high risk for heart disease. That has been studied. In fact, they wanted to study this to see if taking the antidepressants can lower your risk for recurrent heart events. And the study showed it didn't necessarily reduce the risk for recurrent heart events, but it didn't increase them either. So antidepressants are good for treating depression, and we have other medicines that we use very commonly, like statins, aspirin, and other things that reduce recurrent heart events.
Okay, makes sense. All right, last audience question. And I know that we have established in this episode that our systems are quite intricate, and so there isn't just one culprit. But the question is, some forms of birth control can increase the risk of blood clots. Is estrogen the culprit? Dr. Stefanik, do you want to take that one?
There's a lot of evidence that estrogen does increase blood clots, and that's gone for a long time. So probably, but there's lots of alternatives. There are many different kinds of birth control pills, and people should realize that, one size does not fit all. If you have symptoms on one, you can try another one. I will say that oral contraceptives have probably been researched more than any hormones that exist, and we should trust that we have lots of alternatives.
Okay.
But I will say that the evidence for oral contraceptives is that it does increase stroke, but your risk of stroke is so low when you're at the ages that you're usually an oral contraceptive that it's not until you're 35 that we start to really worry. So we do talk about age 35 is where you need to start to see that you need different oral contraceptives than you might have had when you were younger.
All right. Before we let you all go, and this is for the whole panel, so we'll just take turns, what is one practical takeaway you hope listeners walk away with today?
I think the most important thing is to build a care team around you that you trust and that you have a dialogue with and feel confident in terms of improving your long-term cardiovascular risk.
Okay. Dr. Stefanik?
I would say that it's really important for women to realize that heart disease is something that happens to women, and that there are preventive measures. We definitely believe in lifestyle, the Mediterranean diet or something like that, walking, sitting less. Like sitting is a really bad thing. We saw that during COVID. Not smoking. All of the lifestyle issues are really important for primary prevention before you have to start moving into managing cholesterol and all of those things. You can give that a start, but no matter what, realize that heart disease does happen to women and that you do need to go and see somebody if you have any kind of symptoms that might suggest you have shortness of breath, leg pain. You could have ischemia in your legs, which is not enough blood going to the legs.
Dr. Goldberg?
You're never too young or old to prevent heart disease. What you need is a plan. And the heart disease risk evaluation can be started by your primary care doctor, where they can do laboratory tests for your cholesterol and glucose, talk to you about your family history, and start the conversation about how you're going to start your diet and exercise program.
And we'll stay on you, Dr. Goldberg, for the last question, and we'll also go around. What's one shift in research or clinical practice that you believe could revolutionize how we treat women's heart health in the future?
One shift is that we could have a different way to think about caring for patients. And that is that everyone is an individual. That's one thing, to be more personalized in our care, but also in terms of women, to have an appreciation that men and women are different, they're physiologically different, and that you should have a set of questions that you can ask women about their general history, because you can see that autoimmune disease increases risk for heart disease. We have mental health problems that may raise blood pressure, that it's really important to understand that the heart does not work in the absence of the rest of the body. And most importantly is that women do have heart disease.
Dr. Stefanik, one shift in research or clinical practice?
I would like to see more research on pregnancy and postpartum, so that we recognize that if women have a stressful or adverse pregnancy outcome, that we follow that woman through, because she's at high risk for premature heart disease. But also after she's delivered the baby, that we realize that her health is still really important, and that it's very important that she then get back into her pre-pregnancy weight if possible, get in her exercise, do her diet, and get herself back into a place, especially if she's going to have yet another pregnancy, so that she's kind of back into a healthy place before she has the second pregnancy. So in general, I think life course approach, where we really think about a woman's whole reproductive years all the way into this menopause transition and beyond.
Dr. Naderi?
I think clinically, shifting towards looking at patients as a whole rather than organ silos. So not looking at just the heart, but the whole of the person, kind of mind and body and how it connects to the heart. That would clinically revolutionize, I think, cardiology and a lot of medicine. And from a research standpoint, more focused, sex-specific research connecting the basic scientists to the clinical researchers in this translational space, particularly in the hormonal space, I think would really revolutionize how we take care of females.
And we didn't plan that, but you underlined the whole premise of this show. So thank you so much, Dr. Naderi, Dr. Stefanik, and Dr. Goldberg. I learned so much from all of you. Thanks for joining us. All right, so here you go. You can open it up and see what it is.
Okay. Wow. Oh, this is
This
oh my
is
gosh.
the sash. Yes.
This is so cute. Is it a robe?
It is a robe.
Oh,
it is
I
a
love
robe.
it.
Wow,
It's
that's
so
nice.
cute.
You can try it on because it's cold in
Oh,
here.
okay.
It is the robe that patients at the TIA health clinics get
Oh,
to wear
that's so
instead of
cute.
those paper towel-like medical
I love it.
gowns.
Does it open in the back or the front?
It opens in the front.
Opens in the front. Mm-hmm.
That's good. I hate the fact that those open
These
in
are
the
so
back.
Oh yeah, the little
cute.
tie and then
No,
yeah.
I will tell you that yesterday they had at NYU they had these gowns, these paper gowns with snaps.
Oh,
And I asked the patient to open the snap, and it was really hard to open without ripping the gown.
oh
It
my
was insane.
goodness. See?
This is lovely.
Everybody should have these nice
You know,
robes.
this is so funny. So when I was a fellow at Cleveland Clinic, Diane von Furstenberg
designer.
revealed gowns at Cleveland Clinic. And so it was like a thing that like, you
Wow.
know, you're not doing just a regular gown anymore. We're doing DVF ones. So that I feel
How
like
fancy. Yes.
I feel like very
Yes.
fancy. Thank you. That's wonderful.
We have to get together and like wear our robes together.
I
Yeah,
love
we
it.
can take a
Have like a little
picture.
PJ party.
I would love that.
Yeah.
We should definitely do that.
The heart doesn't just beat, it responds to hormones, stress, pregnancy, aging, and everything in between. For women, this means our cardiovascular health is always in motion, and if we're not tracking those shifts, we're missing the story. So not to be corny, but follow your heart. Big thanks to Dr. Marsha Stefanik, Dr. Neica Goldberg, and Dr. Sahar Naderi. Their work and ways to keep a pulse on your heart health are linked below. Hit subscribe for more conversations that'll change how you think about your health.